Okay, so we're really excited for this GeneSight Cares. Just to review the title and what we're talking about tonight. So the title of this is Mental Health Concerns May Be Masked by Unhealthy Coping Mechanisms, and Can GeneSight Help? So good evening, everyone. My name is Dr. Rachel Montel. I'm one of the medical science liaisons with Myriad, working on GeneSight, and thank you again for joining us. So just some topics on the agenda overall tonight in terms of the questions and answers. So if you have any questions, please add them to the Q&A. We'll be monitoring this, and we'll make sure to answer as many questions as we can get to. If we can't get to them, feel free to still send in your questions to the Q&A. And what we're going to do is follow up with the responses to these to your email address. Just another note about tonight, this is being recorded. So this is a recorded session. It's going to be posted to our YouTube channel, along with all of our other GeneSight Cares programs, and the link will be sent directly to your email. Okay, so we have a very compelling program for you tonight, and hopefully our panelists will inspire you to look at your patients and their unhealthy coping mechanisms or addiction through a new lens as we explore how to move patients from engaging in these unhealthy behaviors into treating their possible unhealthy mental health issue. The vast majority of Americans acknowledge a connection between unhealthy coping mechanisms and a potential mental health condition like depression or anxiety. This is according to the Spring 2023 GeneSight Mental Health Monitor, which is a new nationwide survey from Myriad Genetics. And so again, I'd like to thank everyone for joining, and especially thank our panelists. We'll be addressing all of our panelists by first names tonight. And so I'm excited to introduce them to you. So first up, we have Lisa Reyes-Walsh. Lisa is a psychiatric nurse practitioner, educator, and leader who has built her academic career on a strong foundation of innovation by developing accessible, inventive education to enhance the nursing care of vulnerable populations. Welcome, Lisa Marie.
Thank you.
Next up, we have Dawn Galbraith. She's a psychiatric mental health nurse practitioner affiliated with the Indiana Center for Recovery in Mishawaka, South Bend, Indiana. We're glad you're joining us, Dawn.
Thank you.
And then lastly, we have Stephen Panel. He's a psychiatrist and the chief medical officer at Right Track Medical in Oxford, Mississippi. Thank you for being here, Stephen.
I'm excited to be here.
We're excited to have you. So in general, this is a difficult topic, but we want to understand how clinicians are managing this problem of unhealthy coping mechanisms in their offices. So the first question we'd like to ask is, in the context of unhealthy coping mechanisms, what do you see in your practices that can help practitioners identify these behaviors? So we'll start with Lisa Marie for this question.
Okay, so I see really kind of a myriad of unhealthy behaviors, from cell phones, social media, eating behaviors, eating disordered behaviors, either overeating, undereating, and then more recently, the pornography. So having an issue with pornography with social media. So that's been a big issue I've seen lately.
That's really interesting. Next, we'll jump over to Stephen.
Hey, great. Yeah, and I see. So where I practice and operate in Mississippi is mostly in college towns. Oxford, Mississippi, where I'm today, is a big SEC college university town, and so what we see is a huge increase in our teenagers, adolescents, and college students, but a lot of the young professional adults as well. It's been a drastic increase with drugs, alcohol, and what I refer to as gas station drugs. In Mississippi, we have a lot of things that are sold over the counter, that are sort of outside of the purview of being legally restricted. So we just have seen a huge increase with that. A lot of vaping, a lot of these different things that are out there now can be vaped and used in vape cartridges. So ours by far and away is more of a chemical use increase than anything else we're seeing.
Yeah, Stephen, I really liked how you mentioned gas station drugs. Can you just give us a brief summary on what those are so that we're all familiar here, being that we may be from all different areas throughout the country?
Sure. The biggest thing we see is the new, what I call the new deltas. There's Delta 8, Delta 9, Delta 10, which are basically synthetic variants of cannabis or THC type products. We see a lot of kratom. There's a lot of kratom sold over the counter and off the shelves here. Tianeptine, or on the street, what's called Zazas, is making a big presentation here in this area. So those are the primary ones. There's lots of other things too that have different names and different formulations that are sort of considered to be quote unquote supplements, but those are a few to list that we see. The kratom is probably the biggest thing I see in practice, with a lot of different age groups starting to try and use and sort of facilitate in a self-medication way.
Yeah, it's a really good point. So we're going to pass the question over to Dawn, but I actually want to kind of change it up at this point and ask Dawn, do you see these similar quote unquote gas station drugs in your rural community?
Yes. So I get patients and detox them and then carry them all the way through to intensive outpatient. And everything that Lisa and Stephen said is absolutely true. The kratom, and honestly, detoxing someone from kratom is just as painful, if not worse, than fentanyl. It's a struggle to get somebody detoxed off of kratom, and they're using it, it's a powder. So they're just using as much as they want to use. And I appreciate what Lisa said as well, because when we get someone in to start detoxing them, we take away their cell phones because, we don't want them calling someone and them showing up at the facility. Sometimes they're wanting to get out and use, if they're feeling uncomfortable. So we do this sort of dance. And part of it is they're detoxing off of their phones and social media. That's a struggle for them. The pornography. Yeah. So yeah, we see a lot. I see everything you guys talked about. I see it in the detox setting. And then the synthetic marijuana, the spice that's been laced with fentanyl, they get that dopey high, but then people are dying. So, yeah.
Yeah, and I guess you can think of these drugs too as almost an unhealthy coping mechanism based on the fact that they aren't being prescribed to them. So we'll move on to the next question, and I'll start with Dawn, since you're already here and I see you have your mic off. How has COVID specifically changed the addiction landscape?
So COVID, in addiction medicine, we know that when we isolate, that's the first, that's when you're headed down a path that's your first sign, your first red flag. Patients start to isolate, they start to use, they start to drink. With COVID, people were sent home. They didn't have that interaction. I don't know if you saw, I think this morning, the Surgeon General came out with an article and a whole new approach to how are we going to approach this isolation that's causing all these mental health issues. But once COVID hit, our facility went from probably 40 patients to about 140 in about 3 months, because other places were shutting down and people were dying. I mean, I had patients who were dying because they went home and they were drinking, they were working from home, and of course everything's accessible. But then on the other side of that now, I think we have a lot of people with trauma, whether it was trauma that they realized they had in this isolation triggered this childhood trauma response, or if they just, going through the pandemic, they experienced trauma and fear, as that basis. A lot of things I see too are, I get these 18-year-old, 19-year-old kids, and their important years in high school were affected by the pandemic, and they've lost 2 or 3 years of development, in an already time that we struggled to try and figure out what we're doing next. And, the marijuana, then you get into a lot of the addiction issues. So yeah, I believe it's skyrocketed. Personally, I don't know, the other panelists might want to speak to that.
Yeah, so Lisa, if you could share your thoughts on the impact of COVID.
Yeah, so, unfortunately, what I saw with COVID was a lot of lapse in recovery. So I had patients that had long-term recovery that once COVID hit, it really induced an anxiety and fear. And then you couple that with the isolation and then not being able to get to their recovery meetings and, have the support of their network. So it was pretty upsetting to see the amount of relapse that happened. And unfortunately, in a really short period of time, I had double digits losses of patients, which was traumatic for me to experience, because these were patients that I had long-term relationships with now that were and had long-term recovery, were now lapsing in their recovery and then dying from their addiction. So that was the biggest impact that I've seen with COVID. But with kids, I do see some kids as well. I don't have a big, huge adolescent population, but with the adolescents that I did see or do see and take care of, the rise in anxiety has just been incredible, and then depression as well. But the anxiety has just really just been driven pretty high up there for them. And then, their experiences of being online in school and isolated from their friends have impacted them as well. So, and then, thus they fall into these unhealthy coping mechanisms where they're constantly on social media and, and looking at things maybe that they would not have looked at, just to keep themselves and their, their minds occupied so they don't have to deal with the anxiety that they're experiencing.
Yeah, that's all very good points. I'm sure everybody on this call has had patients who have been experiencing similar things in their healthcare setting. So I'll just pass this question over to Stephen before we move on to the next. So again, it's how has COVID changed the addiction landscape in your practice?
Sure. Yeah, for me specifically in our practice, what we saw was a lot of people that were kind of, had mild symptoms, maybe mild to moderate symptoms of anxiety, depression, and maybe even substance use or abuse, maybe misuse. But the schools, the community, the work, and sort of a lot of nighttime and sort of weekend warriors could kind of keep it together to come back to work, back to school, and those things, and they were engaged in their community. Mississippi is a very rural state very quickly, but a lot of those factors were sort of were barriers or protections for them. And when the isolation started and a lot of the COVID things came into play, a lot of this just never stopped for people. We had a lot of people that just started day drinking and just really, they went from a few days a week to maybe on the weekends to really just every single day. And so we saw a huge increase in consumption of everything from food, drugs, alcohol, all the above. And a lot of that was actually connected to just exactly what Lisa was saying about the increase in anxiety, and depression. And I think Dawn made a great point about the trauma things, with so much time and awareness and things that were going on for people to really to have to deal with and process. We had a lot of people that went from having mild symptoms they had dealt with for years that had never really been pathologic, that all of a sudden, pushed them into moderate to severe cases of things. And there's not a lot of resources here. And so we had a lot of people that were turning to self-medication to try to address those things. And very good point. A lot of people who were in recovery or were not in full-blown addiction, lost their recovery. They got into full-blown addiction and dependence. A lot of people that had never been treated for an underlying mental health disorder started seeking treatment for or needing treatment for depression, anxiety, all those things. So we saw a huge increase in just kind of the whole circle of events.
Yeah, and when you're thinking about, mental health in the context of treating mental health or diagnosing mental health, it's also important to think about it in terms of treating. So what were some of the things that you did for your patients or suggested for your patients in terms of treating them during this COVID mental health crisis?
Sure. So one of the things that we had the benefit of is we actually had a big increase in people actually reaching out and seeking care, eventually. One of the things that was surprising to me is how much suffering and how much other things people would try first before they actually reached out to professionals. In a lot of states and especially in Mississippi, there's still a lot of stigma around mental health issues. So a lot of stigma around addiction and chemical use. and things. And so a lot of people would really just get, into a really bad condition before they or their families started looking into that. But when they did do that, it was pretty well received. Part of our outpatient locations where we just saw a big increase in all age groups. Probably one of the biggest age groups we saw was in the 12 to 17-year-old age group. Just huge. You think about middle school or 6th grade, 7th grade, 8th grade, all the way up into the junior and senior year of high school. Just a lot of young people and families were devastated by these symptoms. So thankfully, we had some people in the state, and I think even on a national scene, there was a lot of acknowledgement of some key people that were dealing with this, and unfortunately there were some big suicides that happened during that time, and different things happened with drug overdoses and things. And so it sort of increased the awareness so abruptly and so quickly, almost nearly as fast as it increased the digital age, just like with us now. One of the benefits of COVID is there's a lot more Zoom, a lot more virtual, a lot more digital things that we do now that were, years to decades behind versus where we got to that. So we saw a little bit of that. I feel like the treatment seeking increased pretty quickly.
Yeah, and I just want to redirect that question to Dawn. How did you beyond diagnose kind of treat this mental health crisis during COVID?
Our own or the patients? Yeah, it was a lot, right, guys? I mean, there were a lot of patients that, like Lisa said, we lost a lot of people. The biggest thing I think for us was because we were an inpatient facility and we had opened a new section, thankfully, of our facility down in Bloomington. We still did our best to try and bring some normalcy to bringing people together. And, we were having to use the video cameras, we were having to monitor everybody, but as much as we could encourage that interaction, obviously the medications, the detoxing, the getting people off the substances of abuse, the going back to the trauma, what trauma piece are we missing here from childhood trauma? That the patient maybe is reverting back to. But really because that isolation is such a monster in addiction, the biggest piece was trying to figure out the best way that we could on the fly to still bring connection to humans so that we could all remain accountable, healing, keep an eye on each other. Everybody was just scrambling to do that.
Yeah, great points there. Also, I think, we've spent a little bit of time here now talking about COVID, but coming out of the pandemic, it is still really important to look back and reflect. So I'll ask Lisa this last question, and then we'll wrap it up with the COVID and move on. So do you feel like the mental health crisis is changing back post-COVID, or do you feel like it's still existing in this post-pandemic world that we live in?
From my perspective, it's still, and if not, it's worse because now people feel a little bit more comfortable about getting out, though there still are some people that aren't willing to do that, but they still have the trauma of what they experienced. And so they're still, experiencing high levels of anxiety and even depression and, symptoms of depression. And then I treat a lot of professionals. And so the influx of professionals that I have treated with trauma from those folks being in the hospital treating those patients with COVID has been unbelievable. So that I've seen a huge rise in seeing professionals for trauma.
Okay, so moving on from COVID, we want to come back to this concept of the unhealthy coping mechanisms. So I'll start with Lisa Marie. Actually, we can just follow this up here. So when do you notice that an unhealthy coping mechanism may be addiction related?
Yeah, so that's a really good question. So, there's a lot that goes in that. That's a pretty deep question. But, a good assessment. So doing a really good assessment about some behaviors before and after, did you do that before and what has changed? But this scrolling on Amazon, and you got the boxes stacking up at your house because now you're compulsively shopping, then you have to really tease that out and see what mental health diagnosis is attached to that, or if that's an addiction. Maybe I had a diagnosis of some kind of substance use disorder, and now I'm not going to meetings or going to very many 12-step meetings or my whatever recovery groups that I was involved in. And so now I've kind of fallen into another addictive pattern that needs to be addressed. So that's been a big one. And then food, and so looking at people from this perspective of, tell me about your nutrition, before and after. And so I've seen a rise really in not just overeating, but under-eating as well. And so really being able to tease out anorexia, because anorexia is a big deal, right? Before the opioid epidemic, it was the #1 mental health condition that people died from. So really important to assess that. So it's just a good assessment and really being very thorough clinician, and making sure that you're asking all the right questions so that you can really get a good clinical picture of what that person was doing before and after with that behavior, if this was something new or behavior that they've always been involved in.
Yeah, those are really good points. I mean, I know personally, mental health professionals who have devoted their lives to eating disorders. So, really big, especially, in the context of the world that we live in today. So I'm going to pass this question along to Stephen, and I'm also going to follow this up with how would you also use GeneSight? So again, the question is, when do you notice that an unhealthy coping mechanism may be addiction related? And then when or how do you use GeneSight?
Yeah, so usually when we notice it, it's when things change, and what I consider the change of the daily functioning. You take students who are good students who are now bad students, or people that were doing well at work who are now doing poorly at work, and you sort of look for some, the red flags, and open up the discussion for people to kind of talk about and disclose some of those things, confidentially. I think one of the things I've noticed is that everybody's acceptance level of a lot of things increased, so eating, poorly or not at all was more readily accepted. Drinking more and drinking during the day and drinking a lot was, the bar was just raised on a lot of these things as being, socially acceptable and okay. And, so one of the things we had to adjust was how we asked these questions, and kind of go a few layers deeper with that to look for, excessive behaviors or, dysfunction or consequences from those. One of the things that we see and we deal with here in Mississippi is it's very rural, it's very underserved. And a lot of our colleagues in the communities were getting hit with these things first, urgent care, primary care, family practice, internal medicine, OB/GYN doctors. Most of the patients who really needed help with these things, addiction or mental health or both, were going to the people they knew and had been taking care of them for a long time. Pediatricians in our area were just overrun with teenagers that just really didn't know what to do. So sort of starting that conversation, to open the door. And then a lot of the people we had to come to see us was specifically for targeted treatment for mental health symptoms, whether it be addiction or mental health or both, because maybe they had already failed things. When I talk to colleagues in the community and providers, a lot of times they give it their best effort. They try to start people on medications. They try to do a pharmaceutical approach. And people that deal with psychiatry medicines know that sometimes that cannot be as effective as you'd like. There's a lot of side effects potentially, where people can have a different reaction. And there's a lot of fear around psychiatry medicines, rightfully so. So the way we utilize GeneSight, and thankfully have been in partnership with them for long before this happened, was to do this and talk with patients, talk with families, because even if there have not been any medication trials already, when people are coming in off of street chemicals, drugs, alcohol, other things, it's important to be able to check, to check and discuss with them and talk about a very specific, accurate approach for them to sort of get out of the trial and error approach. And it gives a lot of confidence to patients, gives a lot of confidence to families. Honestly, it gives a lot of confidence to the providers. I mean, we were overrun with people all of a sudden, increased volume of people that needed to get better very, very quickly. There was a huge sense of urgency to near emergency, to get people much better more quickly than usual. And so that's how we relied on and utilized GeneSight, because it gave us a lot of confidence in our first choice medications, our choices, augmentation strategies, gave the patients a lot of confidence. the biggest thing that I use it for that a lot of people don't think about is when we talk about it and we instill that confidence with patients and families, it really helps promote compliance with the medications, which anybody that prescribes psychiatry medications will tell you. Our biggest pitfall is either non-compliance on the beginning or non-compliance during the course of treatment when things have gotten a little bit better. But I find when we go back to that testing and we utilize that real image of what we have as the information, it really instills a lot of confidence and compliance. So that's how we utilize it, to make really good, accurate medication decisions quickly and use the medications to the best of our ability. And when people start to feel better soon, that sort of takes care of itself. So that was the biggest urgency that we felt is like, wow, we've got such an intense, complex case of presentations. What do we do to make the best improvements happen fast?
Dawn, anything from your end?
I would just say, I agree with everything that they said, and that's pretty much, giving somebody just some hope with the GeneSight usually is, when they come, by the time they get to me, they're in an inpatient facility, right? So they've tried everything, they've done everything, they've been using street drugs or not. We also have just a primary mental health facility, and they've jumped around, with multiple medications, 2 or 3 medications. So we're bringing them down off of medication, starting them on it. And the GeneSight is just, you have to start somewhere, for God's sakes. And it gives you that kind of, you sit down with that patient, you say, what have you been on in the past? What do we have here in the green for you? And it just is kind of that nice guide. And I agree with Stephen, that compliance piece, they have more confidence in the medication. And I know this is something that we talked about maybe discussing, but with my patients, I tell them, once we have this combination of meds or this medication that works well for you, I need you to promise me you're going to stay on it for 2 years. Give me 2 years of this while you are being intentional about creating a life for yourself that you can stay sober. And, and we get them, we do our case management, we get them into a good community when they go back home. But that compliance piece, because people start to feel better and then they stop taking their medications. I've been guilty of it myself. So, I'm honest with the patients. It's like, where you're headed, and we want to live the best life we can live. So, yeah, I would just agree with what Lisa and Stephen both said. And that's how I use it as well.
Yeah, and that's a comment that, we hear in medical affairs all the time, is that, GeneSight speaks to enhancing the provider-patient relationship. So I'll turn this over to Lisa Marie, and ask if there are any comments on your end.
Yeah, I would say I agree with Stephen and Dawn 100%. And not only that, I would say that, with patients coming now, normally I would say, okay, you have a diagnosis of depression, anxiety, first line treatment is therapy. Why don't you get with a therapist and get started with therapy, and let's go from there, as long as it's not a debilitating level, right? It's not a moderate, severe to severe diagnosis. If it's more of a mild to moderate, I would say that. But now I'm saying, no, let's get you started on medication, because it's so hard to get in with a therapist. And so the symptoms are, I know they're just going to worsen if they're not going to get the support of therapy. So I'll say, let's get you started on medication. And if there's any apprehension, whether it's they haven't been on meds in a long time, or they've never been on meds, or they've been on many different meds, I take all of those reasons and say that is the reason why we need to do GeneSight, because we can get a much better clinical picture of the way your body metabolizes medicine, so we can make the right choice, hopefully the first time, and get you started on something and get you feeling better right away, as opposed to, kind of putting off and starting with therapy first. Because today, that there's just not something, that I do today, because it's so hard to get in with a therapist. I will put them on medication right away, and it makes me feel better. Yes, it makes them feel better, but it makes me feel a lot better knowing that I'm not playing Russian roulette and guessing at what medication is going to work for them, or what medication they're going to have side effects with, and then just prolong, the suffering that they're experiencing. So I use GeneSight right away.
Yeah, and you brought up a really good point, which is something that we had planned to discuss, which is this mental health professional shortage. So the question that we want to ask is, how do we encourage primary care providers to talk about this with their patients? And I'll pass that off to you, Lisa Marie, since you're.
Okay, I wasn't sure. Okay. How do we get primary care providers to talk about GeneSight or?
To talk about unhealthy coping mechanisms, and then how, GeneSight can help as well, of course, just mentioning that, but.
Okay, so with primary care providers that I talk to, I really try to encourage them to really do a good assessment to whether they think that there's any kind of underlying addiction issues, to not be afraid of that, but to help them by prescribing something to help with symptoms that they are experiencing. So, and if they do think that it's an addiction issue, they can certainly refer that patient, to me, but there are some medications that they can prescribe as well that can help. And so, I talk to primary care providers quite often and consult with them, and will consult with them to help them through the process so that they feel more comfortable. And I think the primary care providers that I work with are now aware of GeneSight because I educate them about that, and they're using it. And I'll give you a perfect example. I had a pediatric provider that was referring a lot of patients to me for GeneSight. And so I called that pediatric provider and said, why are you sending these patients to me? You can do this yourself. And so we had the conversation, and it wasn't that he was uncomfortable with the diagnoses and the prescribing, but he wanted to make sure that it was the right drug. And so he knew about GeneSight and felt comfortable with GeneSight. And so I was able to get him connected with GeneSight so that he could start doing that testing himself.
And I'll pass that along to Dawn.
So, give me the question again, please.
So how do we encourage, since there's a shortage of mental health providers, how do we encourage primary care providers to talk about unhealthy coping mechanisms with their patients, and then also how they can use GeneSight to help?
Sure. Sorry, I get some caught up. I love the other panelists and all their insight and everything. So I get really caught up in that and forget what the question is. When I shifted to do primary care for a little while, it was amazing to me that primary care providers weren't using GeneSight and weren't educated on GeneSight, because it's just a simple way to put you in a direction when it comes to the mental health stuff. If you're the least bit uncomfortable with it, it's a time saver. It's a stress saver. I mean, it just makes life so much easier if when they walk in the door, and almost everybody that walks in your door is going to have at some point been put on, an SSRI, right? Somewhere along the line, they're going to be, or a benzo for their anxiety. Somebody's thrown a benzo at them for their anxiety instead of, getting a little deeper into that. So you have your means to just go ahead and pull that GeneSight the minute somebody walks in the door. Even if you don't think you're going to need it right away, you'll have it. You'll have that information for when that patient comes back. But it's just, to me, it's a time saver. It's a stress saver. It just does so much to help that patient relationship, to help that patient get relief. I love what Lisa said, the suffering, people are suffering. And this is something that, you can't find somebody to do therapy with these patients. If it is, it's online therapy. Then you wind up having, like I did, you have the complications with getting into a meeting because people are not as savvy when it comes to the computers. You don't have that one-on-one, that contact with a therapist. And the waiting is so long to get in with someone. We've got to do something quickly. And this is an easy way to have some confidence. It's not expensive. You guys make it so easy for the patients and for the providers to get it done quickly. And then you can have some confidence and bring some relief to the patients.
Excellent. And then Stephen, do you have any comments on that?
Yeah, I mean, my comments would be is just it's very empowering for any provider to have this tool to work with if they need it. I think, in our community, people that are seeing this way before I do and probably dealing with it a lot more than they planned on, are in the primary care space and in other healthcare specialties where they didn't really plan on, addressing the large part of the mental health crisis this country is in, but it shows up in their office every day. And so for me, having this tool and feeling empowered that, if a person, can open the discussion and feel comfortable with, if the patient asks me for help for this area, I have a tool now where at least I feel comfortable starting something, and then like you're talking about the process of whether they use it or not, it's there, it's available. And also sometimes getting something started to help a person. And then, in the meantime, while they're making a referral for a therapist or a psychiatrist or somebody that may take a little time for them to get into. And to me, that sort of bridges the gap of feeling uncomfortable about it and just trying to avoid it and not wanting to talk about it or bring it up. Because, if we're all being honest, we don't really want to discuss things if we don't have answers, if we don't have a solution, for the person that's in front of us. And I think this really helps create solutions for people that, are looking for them.
Awesome. So I want to come back to this concept of unhealthy coping mechanisms. And Stephen, I'll start with you since you're still here. So what do you look for if a patient doesn't tell you that they're using specific behaviors or specific unhealthy coping mechanisms? What are some of the things that you look for to kind of identify whether they are or a mental health diagnosis?
Sure. So the things I look for are what I call the unexplained changes or the unexplained consequences, or things that get told to me as sort of this long kind of ongoing chronic series of unfortunate events, and then they start to pile up over time. And a lot of times it's because the insight into the underlying behavior is not really established. And it's one of the things that we talk about as being in denial or having resistance to things. I mean, you see this in every level of illness. Sometimes, people in the family and people that know the person will see it, very clearly, and they sort of see something as being a problem, but the person who's actually doing this to themselves every day has not identified it yet as a problem or even a cause. You can look at things like we talk about with food. People can gain a large amount of weight, but they don't think it's a dietary problem. They can lose a lot of weight and be very unhealthy, and we don't really consider it a nutritional problem. And so much of our healthcare society has gotten into kind of avoid, deny, and not really want to address until there's a crisis. So those are the things that I sort of look for. The unhealthy coping piece of that becomes a lot of the irrational behavior of trying to make things still work when they're not going to work anymore. So, I think that piece, and one of the things we rely on a lot is collateral information. I always encourage people to bring a support person with them to the appointments, to get a different perspective and ask collateral information, especially for young people. People in the 12 to 17-year-old age category, but definitely, a lot of the college students that I take care of, they're 18 to 26. A lot of times we will Zoom in a parent, or we'll have somebody join us, with permission and consent, of course, but to get another person's perspective, because sometimes that helps kind of address the hard to talk about topics. And then it helps me from a very, strategic point to be able to help them clinically, because a college student may tell me a very clear perception of their recent events. And someone else that's close to them may clue me into some things that really are important that without knowing them, I can't help them.
Yeah, that's a really good point about bringing someone else in. It's something that I hadn't even considered, but they could probably point out these unhealthy coping mechanisms that maybe the person is unaware of. So I'm going to pass this question off to Dawn. And just to repeat, this is looking at what do you look for if a patient doesn't tell you that they have an unhealthy coping mechanism, but those behaviors are present? How do you identify them?
It's interesting because we have a dual diagnosis floor, and then we also have a primary mental health floor. And there are often patients that, will staff and it'll be like, yeah, we actually need to get them up to, the dual diagnosis floor, because they'll come in with mental health issues and we'll be talking to them about their mental health issues, coping, and they may have been in some kind of even a mental health system, or seeing a provider outpatient. And then, we, based on the initial information, we may put them on the mental health floor to try and stabilize them. And we realize, they've been self-medicating this whole time. They've not been telling their provider, they've been severely depressed, and the alcohol consumption's gone up, which has caused more depression. And, they've not shared all of that. So it really is, asking those questions. And I think, patients often try to hide information because they're embarrassed. And I often ask the patients, what was it like when you were at your best? Tell me what your best life looked like. And so, everybody can answer that question because usually it was before COVID. That's that big time frame. But I'll ask them, what was your best life like? What did it look like? What was going on in your life during that time? Do you want to get back to that baseline, or do you want something even better? And then have that conversation. And sometimes that'll kind of open it up to, okay, this is what's happening that keeps me from having that life. And then they'll maybe be a little more open to share those things.
Yeah, that's really interesting to think about, having a previous experience that you want to get back to, or moving forward to a new experience that you think will be even better. And so I'm going to pass that question off to Lisa Marie. And just again, the question is, how do you identify unhealthy coping mechanisms when a person isn't exactly identifying them for you, and how do you pick up on the behaviors?
Yeah, thank you. Thanks for repeating the question, because I was like Dawn. Every single time you asked me to talk, I thought, thank God she just asked the question again, because I've been intently listening to both Stephen and Dawn and really have appreciated their contribution. So to answer that question, I really educate all of my patients first on the first visit, and really explain to them what addiction, my perception of addiction is. And I describe it as a ball, and they may have a little tentacle that pops out that's alcohol, right? But addiction is addiction, and it's just this big round ball, and other little tentacles can pop out if they're not careful. So they need to be aware. Food, sex, shopping, so forth and so on. So I talk about the unhealthy coping from that standpoint, and tell them that this is something that they do need to be aware of, because sometimes people shift addictions, right? And so another little tentacle might pop up, if they're not really paying attention. And then being very deliberate about asking them questions when they come in. So how's your eating? What does your eating look like? Because a lot of times patients that come to treatment, or come, from, long time use of some drug or alcohol, they really have unhealthy eating habits when they first, stop using the substance and they get abstinent. They might start eating a tremendous amount of sugar. So I warn them about that, right? That, the dopamine that they were getting from their drug of choice, they are no longer getting. So their brain is going to be craving something. And so if they're getting that dopamine hit, right, from being on social media and hitting that like button, they need to be aware of that. If they're feeling low and they decide to go eat some sugar or eat a piece of cake or a dessert of some sort, and all of a sudden they feel good, they're going to get that dopamine hit and they're going to want to go back for more. And so sugar is one particular substance that I have seen a lot of issues with, especially those with alcohol use disorder, because of how alcohol metabolizes in the body. So I really do a lot of patient education up front about that. And then I check in with them. So tell me about your eating. Tell me about your exercise. Tell me what you're doing. Tell me about social media. How are you doing on social media? Are you going to Zoom meetings? What are you doing? So asking them that holistic view of what their life looks like. And then Stephen, the point that Stephen made about, if all of a sudden I have somebody saying, oh, my grades have gone down, then I'm asking them, so are you on social media a lot? Tell me, and then diving deeper and asking those questions to find out if maybe it's a stressful class or a hard topic for them, and they're trying to check out, right, and do some kind of unhealthy behavior. And then one unhealthy behavior that we really haven't talked about is cutting. So really looking at my patients. And so if my patient comes in with short sleeves on all the time, and then all of a sudden now I'm seeing, jackets or long sleeve coats or shirts or something like that, kind of hiding and covering things, then I get concerned, right? And I'll start asking those questions. I've had patients that, pull out their hair and they'll come in with a hat on. And so I've got to tell them, take off your hat, I'd like to see your hair, see what's going on there. So yeah, just being diligent about the education upfront and then doing the follow-up, not just educating them, but educating them and constantly following up about those things.
Yeah, and then I'll follow that up with you with when does the diagnosis come in? So when are you, kind of talking to them about these unhealthy coping mechanisms that are actually, these underlying mental health issues, and taking it a step further, then when would you introduce GeneSight as part of their treatment?
So, as far as diagnosis goes, I leave that up to my patients. Some of my patients, they don't want to know what their diagnosis is, right? So they don't want a diagnosis, but we can talk about symptoms. And so I'm always treating symptoms anyway. I am lucky that where I practice, I'm not accountable to insurance companies, so I don't necessarily have to give a diagnosis. But if that patient wants a diagnosis, I'll certainly give that to them. But if I see that the patient has and meets the criteria for, let's say, major depressive disorder, then, I'll incorporate GeneSight in that so that I can get them, on the right medication. And I can tell them that you have the symptoms of, and tell them what the symptoms are, and this is why, and this is what needs to be medicated. They're usually on board with that. If I give them a diagnosis because they want a diagnosis, then they're perfectly okay with that. I still do the same thing. I tell them what the symptoms are, what the criteria is, why they've gotten that diagnosis, and whether it's mild, moderate, or severe, and what my recommendation is as far as I think you need to be on medication. And like I said earlier, I tend to put people on medication quicker now because of the mental health shortage with being able to get somebody into therapy and get the support that they need.
Yeah, that's a really good point about the mental health shortage. So I'm going to pass this off to Dawn. And again, this is when does diagnosis come in when you're looking at these unhealthy coping mechanisms? And then when would you introduce GeneSight as part of the treatment?
So as far as the diagnosis, I love what Lisa said. I, of course, have to diagnose, right? Because they're in an inpatient setting. So we're going to use the DSM-5. We're going to use our measures, our PHQ-9, whatever measures that we're going to use. I will say that if a patient has trauma, I will give them these diagnoses, or we'll talk about these diagnoses. And I'm very careful with the borderline, the bipolar disorders. But when they have trauma and you have a trigger and you're going back to an age of trauma, it can look like different diagnoses that is actually just trauma related. It's just PTSD. So I sit and have that conversation with the patients. I get out the DSM-5 with them. I talk to them about, the different criteria, and then we talk about their trauma, ages of trauma, and what a 3-year-old looks like when they're throwing a temper tantrum, even though they're 50. So that's a big piece of it. But yeah, I will put their diagnoses in, and for me, I'm in an inpatient setting. I'm doing the GeneSight the minute they walk in the door. They've already failed medications. They're already in a dire situation where we need to get the right meds going as quickly as possible. Typically, I'm going to start something that I know is going to be appropriate for them to bring them relief quickly. And usually we have where we start a loading dose on medications anyway. So I'll start that loading dose, and typically I'm going to get the GeneSight back in 3 to 4 days. And I can either switch to something else at that point, or I can just continue with those medications that I've picked initially. And Lisa Marie, what we call that changing seats on the Titanic. When we jump from one addiction to another addiction to another addiction. So the patient comes in and all of a sudden they're getting clean and they're falling in love with someone on the floor. And I'm like, yeah, you're just changing seats on the Titanic. You know how that's going to play out, right? So yeah, still going from one addiction to the other, still going down and not dealing with typically a complicated grief usually or trauma. So
yeah, I like that both of your responses had to do with education, which I think is just so important, to not leave patient out in the blind, but to take the time to educate them. So Stephen, I'm gonna turn this over now and kind of switch gears and ask you the question of, how do you prevent an unhealthy coping mechanism from becoming an addiction? Or what do you do to maybe educate or, inform your patient to prevent their unhealthy coping mechanisms from becoming an addiction?
Yeah, thank you. That's a great question. I think the biggest, most important thing in that area is early awareness and early intervention. It's one of the things you hear about in other areas of healthcare and things like that, but I think it's one of the ones with the stigma and just a lot of the things and the fear and isolation around mental health and addiction. It's something we need to be doing a lot more of. So one of the things I talk about families and talk with people about is early awareness and intervening early and just being open to the idea that something may be going on that we're not aware of. The digital age has connected everyone in the palm of their hand with more people than they've ever been connected with 24/7, at the same time isolating them more than they've ever been isolated in their life. So that's part of the piece we bring up. When I go through the statistics with parents and families and other people, and I talk about the number of 12 to 17-year-olds out there that are chemically altering themselves on a regular basis, either through abuse, misuse, or either just exploration. It's really one of those things that blows people's minds, and they really have a hard time considering that, especially if they have kids in that age group or family members in that age group, or extended family. I mean, it's become one of the things through this whole crisis that very few people are left unaffected by it. I mean, it's one of those things. We all know somebody who's either directly or indirectly affected, either through a family member or someone they know. So I think that's the biggest piece of it. And I think with the education and the awareness of it, what we try to do is then bring some normalization to the process, help people to understand it's a very isolating, very lonely place to be, but you are not alone. You're not the only one that's been here. You're not the only one that's going to be here. And just sort of, I don't want to say normalizing it, but I do want to say bringing just sort of a more approachable place to talk about those things. So then people can then become aware of it and take action, take change to do things differently. The biggest thing I see here in Mississippi is people are scared to death of Prozac and psychiatry medicines and things like that, but they will try anything else under the sun. I mean, mushrooms out of a pasture, gas station drugs from wherever they come from, illegal drugs, that sort of stuff, and even a lot of the stuff they can get off the shelves, it's just, so that's one of the pieces I think we have to bring up with awareness with people. I can't tell you how many people, like Dawn was mentioning earlier, trying to get people off Kratom that just had no idea that it could be so addictive, it could be so dangerous and those things. So, the way we do it is early education, awareness, just trying to keep an open dialogue with people about this, and just having people feel comfortable talking about it, which we've seen an increase with that. Thankfully, some of the benefits of the crisis as we've been through recently has brought an increased awareness and sort of acceptance of this. So I think that's the biggest part.
I would like to add, what I often tell my patients, especially when I'm doing groups with them, is we have got to start normalizing the human experience. Everybody has experienced depression or anxiety or some form of trauma or not knowing how to deal with a situation or fear. And, if not, like you said, Stephen, if nothing else, these things all came out during COVID, where we all realized we're really not okay. We've just been busy. And so, if we can normalize the human experience and we can just say, you know what, it's okay. It's okay. We can start talking about this. It's okay. Everybody feels this. You're not, I remember the first 12-step meeting I went to, and somebody actually came just forth with his abuse or his addiction problems and shared with the group. And he was like, bam, this is me. And I remember how normal I felt. I thought, oh my gosh, okay, other people feel these things that I felt so isolated with in my own mental health and addiction issues. So, we have to start having these conversations and just normalize this. This is normal. We've just not talked about it. So that's all.
Well, thank you, Dawn, because I didn't have to pass the question off to you. So I'll ask Lisa Marie to comment on that. And again, it's what tactics do you recommend? Sorry, hold on one second. It is, what tactics do you recommend to prevent an unhealthy coping mechanism from becoming an addiction?
Well, I think Stephen said it 100% best. And it is just really that, just like anything else in healthcare, we talk about prevention, and give the education of the stats and what the risks are and risk factors are. And so really, talking to patients about that and having that open dialogue from the get-go about that, and patients' families, they need to know that. And I'll go anywhere and everywhere that someone will listen to me to educate about addiction and prevention. And so, I just came from a day long of educating a university about substance use disorders amongst healthcare professionals and what that looks like. And, it's a perfect example. In nursing schools, we don't educate nursing students about what their risks are. And nursing students are at higher risk. They are a vulnerable population. And we don't talk about that in nursing school. So anybody that wants me to come to a nursing school and talk about that, I'm your girl. Sign me up. Because we need to talk about it, just like what Dawn said. We need to normalize the human experience.
Well, Lisa Marie, if I come across any nursing students who are struggling, I will definitely send them your way. We do have a question from the audience, and we don't have much time left, but I think we could get through it. So Lisa Marie, I'm going to direct this to you at first. The question is, after receiving the GeneSight results and starting a patient on a medication, but say that medication over time does not produce the level of therapeutic benefit that was expected, how do you approach this type of result with the patient?
So I personally will ask them about their changes in behavior, changes in eating habits, different things. What time of day are they taking it? Are they taking it regularly? So there's a lot to assess around that. Because depending on the half-life of the medication, they may have been taking it, one day at a certain time, and then the next day, 6 or 7 hours later, which can impact the experience that they have. And then a lot of times, and this is what I see mostly, is that patients think the medication isn't working and they want to come off of it. And I say, all right, well, if we've assessed everything else and you really think you want to come off of it. And as we're tapering down, they realize, whoa, wait a minute, my symptoms are coming back. So for a patient like that, I usually taper them down really, really long and slow, so to speak, so that they get to experience and they usually go, whoa, nope, can't do without it. I realize it was working. Let's get me back up to where I was.
Okay, I'm going to pass this off to Dawn, and I'm going to repeat it just so that we all remember. So after receiving the GeneSight results, if you start a patient on a medication and over time it doesn't produce the level of therapeutic benefit that was expected, how do you approach this type of result with the patient?
So a lot of times I will ask the patient to journal. I like what Lisa Marie said about their when they take the medication. I'm going to assess sleep. I'm going to have them journal. And I'm also going to ask them, again, going back to that trauma, do we have a seasonal affective disorder now? What time of year is it that depression's starting out? A lot of times people don't know what normal feels like either. So I'll have a patient who they'll say they want to come off of the medication because they don't feel right. What are you experiencing? And what they'll describe to me is peace, but they're not used to feeling peaceful. And so they don't know what to do with it when the medication's working and they're not getting in the middle of a fist fight in the parking lot, because normally they would overreact to a situation and now they're calm and can step back. So it's really just having that conversation. Do we need to add a mood stabilizer? Do we need to what do we need to add to that medication? There might be certain times of the year we need to add something to the antidepressant to kind of help get them through, say, the winter months, or a bad time of year that they didn't realize was the anniversary of something. So yeah, having those conversations. And I'm not big on going up real high on medications. We kind of have our standard that we go with, and then we can go higher. I like to kind of assess and see, what are we maybe missing here that we need to add to it? Are they going to therapy? Did we get them in with a therapist? So there's a lot of different things you can assess with that.
All right, Stephen, I'm going to pass this question off to you. And again, this is our last question here. So after receiving the GeneSight results, if a patient's been started on a medication that over time doesn't produce the level of therapeutic benefit that was expected, how do you approach this type of result with the patient?
So usually I approach it a couple of ways. I do like to ask kind of what their expectations are of the medicine, because sometimes the medicines are a little slow in the results and the change is kind of, mild over time, and it is a significant improvement that takes a lot of time to sort of take impact. Sometimes it can be so slow the patient doesn't notice it or doesn't realize it. Honestly, a lot of times what I do is I do circle back to the people I've engaged in their treatment to make sure that they are taking the medicine. One of the basic things I do a lot of times is call the pharmacy and see if they pick the medication up. The number one reason I have for medicines not working in the people I prescribe them to is they're still at the pharmacy. Which sounds irrational to say that, but I think, you'd be surprised how many people I work with and train. And it's the first thing I tell them to do, call the pharmacy and see if they picked up the medicine, because we have to at least make sure it left there. But, if I feel like all those things have been addressed and we've done an adequate trial over time, then I will discuss with them that sometimes just because it's in the green category and we understand the metabolism of it does not guarantee the efficacy of it. It gives us the right idea, the right direction, and the right tool, but it doesn't guarantee efficacy at the receptors. But, we didn't have bad results. We didn't have side effects. We didn't have suicidal thoughts. We didn't have, things that were very negative as a result of that too. So it allows me to facilitate a change to an alternative medicine, maybe an augmentation strategy. But the biggest thing that I deal with is most people are not used to going through a full trial over 3 to 6 weeks, sometimes longer, raising the dosage slowly over time. There again, I hate to keep saying the same thing over and over, but my number one thing in a lot of these cases has been non-compliance. People are still just a little bit afraid of the medicine, so that's how I address it. If they really are not motivated for that medicine anymore, we may need to switch medicines, but we usually do that in the right amount of time. We don't just jump from medicine to medicine and do things very rapidly that way.
Yeah, and again, just the adherence factor and also kind of establishing this patient-provider relationship and establishing trust really between the two. So we are at time. I want to say thank you to everyone who joined. Thank you to our panelists. I think this was a great discussion. I'm sure we all learned a tremendous amount. Just some housekeeping notes. As I mentioned, there are several questions in the Q&A. I see them. We're going to answer them. You'll be receiving an email with the answers to the questions, as well as a link to our YouTube channel where this session that was recorded will be posted. So again, thank you everyone, and we appreciate your time.